Hello, my name is Ben Butler. I'm the Chief Information Officer of Cochs. For those who are interested, this video is available through a link on our website on the home page under the What's New section. Of course, it's being called the Unseen Provider. Just click on that, and when you go back to your offices tomorrow, you can have people view it with you. I would like to thank the Robert Wood Johnson Foundation for funding this video. Before I introduce the next speaker, I would like to remark on how well the video we saw lays the foundation for this panel discussion. Jails and healthcare are complex topics, but when we combine these topics, their complexity grows greatly. What we just saw in the Unseen Provider was a small part of that complexity. When I first started working with Cochs, I envisioned that health care delivery in jails would be analogous to primary care facilities. But health care in a jail is not so easy to categorize, and it is certainly more complex than a primary care facility. Healthcare systems in jails are more like complex medical delivery systems that in large jails often include infirmaries, which in some cases parallel an inpatient facility, primary care and chronic care, and specialized mental health and substance abuse units, which are similar to partial hospitalization programs. Another challenge of categorizing healthcare systems in jails is that typically primary care practices do not have in-house pharmacies, but jails frequently do. Thus, jails need to keep track of medications that are prescribed and dispensed. Besides all these multiple health care delivery systems, jails are most importantly a place where custody and control and safety come first. As you have read in the paper, implementation of an electronic health record in the New York jail system, the EHR at Rikers Island was the electronic health record system that the Primary Care Information Project selected for participating primary care providers in New York City. This EHR was suitable in a primary care facility, but had to confront many challenges to be useful in a jail environment. To speak to these challenges, I would like to introduce Dr. Homer Venters. Dr. Venters is the Assistant Commissioner for the Bureau of Correctional Health Services for the New York City Department of Health and Mental Hygiene. In this capacity, Dr. Venters directs all aspects of health care in the New York City jail system. Dr. Venters received his MD from the University of Illinois, completed his residency in social internal medicine at Montefiore Medical Center, and a fellowship in public health research at the New York University Langone Medical Center. Dr. Venters is also a faculty member at the NYU Center for Survivors of Torture and co-chair of the ICE NGO Health Advisory Group, which advises the U.S. Department of Homeland Security on medical care for detainees. After his speech, Dr. Venters and I will join Dr. Stephen Summers in a panel discussion. Stephen Summers is the President and Chief Executive Officer of the Center for Healthcare Strategies, which he founded in 1995 with a major grant on Medicaid managed care from the Robert Wood Johnson Foundation. Before starting the Center for Healthcare Strategies, Dr. Summers was an Associate Vice President and Program Officer at the Robert Wood Johnson Foundation. Prior to that, he was a professional staff member for the U.S. Senate Special Committee on Aging and legislative assistant to U.S. Senator John Hines of Pennsylvania. Dr. Summers serves as a visiting lecturer at Princeton University's Woodrow Wilson School of Public and International Affairs. Dr. Summers earned his PhD in the politics of education from Stanford University. Please welcome Homer Venters.
I'm just going to talk about 8 minutes. Is that okay?
Great.
Good morning. I wanted to say first thank you to Cochs, to Steve, to Ben, to all the other Cochs, folks who have put together just a fantastic day. It's very, very impressive. I also wanted to thank and recognize my colleagues from New York, Dr. Summers, Cecilia Flaherty, Rick Stazeski, who's sitting right here on the aisle, who is the one who did most of the hard work to get this EHR rolled out on the island. And so he, more than anybody, deserves accolades for the attributes of the system. And the clinicians, like myself, probably deserve the knuckle rapping for the shortcomings. So we, in 2008, started rolling out an electronic health record, ECW, in the New York City jail system. So as you probably know, it's a big jail system. It consists of 12 different jails now. It was 11 at the time, but it's lots of jails that look like medium-sized jails, 9 of them on an island and a few others in the boroughs of New York City. So it's a pretty complex and fragmented correctional health system, so it's up to the task of mirroring our healthcare system writ large in the community. So we started with the women's facility in 2008, November 2008 at the very end. Implemented, went live with the EHR there, and then we rolled it out across all of the other facilities through the spring of 2011. So as Ben just mentioned, you all know very well, I think most of you, what all the different types of care provided in correctional settings are. I think that the thing I would say about jails and our jail, I think in particular big urban jails, is it's incredibly chaotic. And so we have lots and lots of intakes being done. In our system, unlike others, this is a several-hour process. It looks like a hospital admission and physical, so it's done by an MD or a PA, and it takes several hours. We do all sorts of work with universal offer of HIV, with vaccinations, screening for mental health issues. So this big process then was switched over to our EHR, and I think was probably one of the biggest challenges for us. In addition to intakes, we have ambulatory care, follow-up visits that are very common in jail, sick call, emergency responses, infirmaries. We also have a communicable disease unit that functions to rule out TB, and where we send folks with like varicella isolation. So we have lots of different types of healthcare that we're providing. ECW, as you may or may not know, is a very solid ambulatory care product that we and Rick worked very hard and continue to work very hard to adapt to our system. So to the extent that the type of care we provide mirrors what ECW is built for, it's been a pretty good implementation. I think the farther we get from that, the more we get into things that don't look like ambulatory care, the more we did run into challenges, and we have worked and continue to work on ways to modify the product and in some cases modify our workflow to work it in. I think anybody who's considering an electronic health record will ultimately contend with this notion that some of your care delivery will have to change in order to accommodate the product you get. I think that that's one of the key lessons for us. I think 2 other lessons I want to impart. One is that the EHR, whatever it is, will shine a very uncomfortable light on some bad clinical practices that we have, that you have, that everybody has. So we spent a lot of time thinking about how do we get a team together to train our providers, to go live, all the process and logistics associated with implementation. What we didn't expect, and what I think continues to surprise us every time we implement any new technology, is that you find out all sorts of things you're doing clinically that don't make sense, or that you thought you weren't doing, or you need to fix right away. And so it creates this huge challenge for the clinical leadership to not only work with your clinical staff to get ready for this new change and accommodate the new change, but all of a sudden you find out you're doing blood pressure readings the wrong way, or you're not prescribing what you should be prescribing, or you're responding to emergencies without ambu bags half the time, because now you can look at the notes and find out, holy crap, you went to the housing area with no ambu bag for a patient that was down, and it's right there for you to see now. It's not secreted away in a paper chart. So that is the second lesson I think I would impart to you, is that it really shines a light. So get ready for your clinical staff to do lots of work that's purely clinical as a result of having implemented this new technology. And the third is that I think it is not, for much of our work, it is not a net gain in productivity. Some of the tasks, in particular the tasks that happen in corrections that are process-oriented, that are laborious, those will become more laborious for many of your clinicians. And I'm sure it depends a little bit on the electronic health record you select, but if you take something like intake, which is a very process-oriented. You're triaging, you're looking for people who might go into withdrawal or people with heart conditions or insulin-dependent diabetics. You're looking for a small number of patients, but to do that, you're doing a lot of work, a lot of routine interaction. And in those settings, we find that the health record, people who are very, very good at intake, either PA or MD, who could do, let's say, 10 or 12 in a shift, might have gone down to doing 8 in a shift or 7 or 9 in a shift. And we haven't gotten back to, they certainly have not gotten back to the level of productivity they had before. There are other areas where we've had a gain in productivity. Some of the ambulatory care venues, I think, are a little bit more efficient, but I think that I would caution that, all the different, everybody in this room has very little margin for extra work, right? You have slim budgets. They're smaller this year than they were last year. You have fewer staff this year than you did last year. You probably have just as much work to do, if not more. And so as you contemplate rolling out an EHR, it's important to realize you will need to redistribute some of your resources to accommodate the productivity consequences or implications for the EHR. The final thing I wanted to mention is the EHR has great benefits, and I think we, in our healthcare endeavor, think about correctional health, certainly with regard to connectivity to the community, which is coming, and there are lots of folks in the room who know much more than I do about it, but we certainly look forward to that, to connecting this amount of information to the outside. But for inside the correctional health system, we have these 3 frameworks we think about for how we deliver healthcare. So the first is patient safety, and this is something that's very well known to most people in correctional healthcare, certainly people in the community. So thinking about, do we deliver medications the right way? Do we find out about adverse events? Do we have a way to monitor and record doing things the right way or the wrong way? And so an electronic health record certainly is a boon to that mission, to promoting patient safety. You can read what people have written. You can see when something was prescribed. You can find out if it was delivered or not. So it's really a big plus. A second framework we think a lot about is public health. And so how does the health of the population in front of us and their back and forth with the health of the population in the city, how are we doing there? And so tracking things like outbreaks or the incidence of different diseases, or overall, how are we doing with our diabetics? Are we increasing, how are the A1Cs looking? Are we getting more finger sticks done? That type of population health or epidemiologic approach is really important. EHRs are really important to promoting that in corrections. And the third, which is, I think, far afield sometimes for us in corrections, although certainly not for our colleagues in Europe, is human rights. And what I mean by that is we in our systems have people that are not just high utilizers of care, but who are vulnerable individuals. And they're vulnerable by dint of being part of a group. And that group may be the people who are mentally ill. It may be people who are LGBT. It may be people who are a different color or a different gang or whatever. And in our system, we provide a lot of care and we do a lot of things. And so those first 2 frameworks of patient safety and of population health and epidemiology, I think those are really key. But I think the thing that the electronic health record, surprisingly to me, helps us with is to keep track of, are the people who slip through the cracks slipping through the cracks? And are we as providers doing an ethical and moral job of finding them and of advocating for them and of making sure that our position and our relationship doesn't get pushed off its mission? This problem of dual loyalty that every one of us in corrections faces, that we answer, even us in New York City where we answer to my boss's commissioner of health. So we theoretically don't have this, but we work in a security setting. I think, as Ben just said, security rules the day. So the electronic health record provides a venue to keep track of our central mission, which we're there to care for patients. We're not there to clear bodies for security. We're not there to help the sheriffs or whoever the custodial or security staff. We're there to care for those patients. And so to the extent we can build, and we have built, we're just starting to build some tools in the electronic health record to find vulnerable populations, to find out, are they doing well? A good example is injuries, trying to find the rates of injuries among different groups, and others, people who go into solitary settings, the mentally ill who sit there, to come up with specific note and visit types that let us know when somebody's decompensating. We're just starting to think about this. But those 3 frameworks, patient safety, it's a clear win. The second, population health and epidemiology, I don't think you can pursue that mission without an electronic health record. And then human rights, I think here in this country, we really need to get comfortable with the terminology and the language around human rights. And I think that electronic health records, paradoxically, are a venue for starting that discussion. So, thank you.
Thank you, Homer.
Thanks.
Homer, in your paper you stated that one of the benefits of the EHR was that the providers in jails could view the inmates' health records from previous incarcerations. How would it change the practice at Rikers if you could fill in the gaps and see the health records generated between incarcerations?
I think there would be two big gains. I think the immediate gain that we can all think of is all this work we do on intake, all these labs we order, or medications we prescribe, we can do much less work and much more intelligent work on behalf of the patient. So we wouldn't need to get an A1C on everybody and a CD4 and a viral load and all of the incredibly expensive labs and tests we order. I think that, though, that speaks to a much bigger gain and a much more fundamental problem in corrections, which is I can't tell you how many M&Ms we're at, and we just, at the end of the day, are saying, how come we can't get our providers to look at the patient in front of them and pay attention to them, right? Like, are they getting worse? Are they getting better? Part of that is we create this barrier for our providers. I mean, we ask them to do all this crap on admission, right? Like, our admissions are hours long, and we do this and this and this and this and this. And to the extent that we can, like, make this less of a rote process because we have information from the community, because we can immediately sync up. If I'm doing an intake on somebody, I'm finding out what goes on with them in the community. I know what their A1C is. I know them as a person. You know, I'm thinking about them as an individual. Then I think it helps us on this much more broad mission of paying attention to the patients as they're in front of the providers, because we're not just every diabetic gets this and every person with HIV gets that. And I think that and it also obviously is a huge boon to the patients and the community because we can continue their care and their medicines. But it's just something we absolutely have to do. It's a complete mandate for us to figure out how to do it. I'm glad there are smart people who are figuring it out, and I think it will radically change the type of work, the amount of work, and my hope is the interaction with our patients in our settings.
Steve Summers, if the Supreme Court upholds Medicaid expansion, how important will it be come 2014 that jails are connected to health information exchanges?
Well, I feel like I should step back just a second and say where I'm coming from. I feel a little bit like Seema when she said she was learning a whole new language, and Steve Rosenberg and you are all exposing me to the other side, the Department of Corrections side of this discussion, or the corrections side of the discussion. And so I feel like I'm here kind of as a connector. I'm not a clinician. I can't speak as eloquently as Jeff Brenner, certainly, or they're a federal official who's writing the laws or interpreting the laws. And I'm not even a Medicaid director, but I do work with a lot of Medicaid directors and with folks from health plans. And from that vantage point, I'd have to say that this is an incredibly important opportunity because, as I think Nancy Barron eloquently outlined, there's so much overlap between the Medicaid expansion population and the population that are seen in the jails and that are cycling through 9 million, 10 million unduplicated count every year, and the characteristics of behavioral health problems, substance abuse problems, all of them will, or almost all of them, will be eligible for Medicaid in 2014, Supreme Court willing. And right now, the system between, as Jeff Brenner was saying, the system between healthcare and the jails is disconnected. Unfortunately, there's a fair amount of disconnection already in the health side between physical health and behavioral health and substance abuse. And the HIT systems that are being developed are better on the primary care side by far than they are on the on the behavioral health, particularly the substance abuse side. So there's a lot of work to be done on both sides, but the connectivity issue, as Homer was saying, is huge because you're losing track of all kinds of information that's very valuable for managing the care of people whose care needs continuity more than almost anybody else.
I know prior to this conference, you had an opportunity to go to Rikers and see the systems in New York City, which they've implemented. How do these systems fit within the overall paradigm of Medicaid managed care plans?
Well, I was very, very impressed by what I saw at I guess it was the Tombs, right, and the jail system in New York. And I also visited Camden, so I've seen both, and I've seen that there isn't the same capacity, certainly in Camden, as Jeff indicated, as there is in New York. But what Homer and his colleagues are trying to do in New York on the corrections side is what you would hope that managed care organizations across the country are doing on the physical health, and to the extent that they can get connected to the behavioral health side. They want that information in order to manage the care of their beneficiaries, because if they don't do so, and if they don't have the data to know what's going on and what drugs have been given, what care has been provided, they're likely to see these people that are going to be enrolling in their plans in 2014 run through emergency rooms and hospitalizations in the same way they currently do. And that's obviously not something that healthcare executives, managed care executives want to see happen, because those are avoidable costs in their eyes, and information systems are incredibly important to that. And some of the managed care organizations in Medicaid have developed very sophisticated information systems and capacity to extract information to help manage the care, particularly of their high-cost, high-need beneficiaries.
Do you have any thoughts on managed Medicaid, Homer?
No, I would.
You would.
As Steve eloquently stated about corrections, this is a field I'm just learning about, which is why we have in-house experts with us today.
Yeah. Didn't mean to put you on the spot, but if you want to contribute anything, feel free at any time. And about integrated data systems, Steve, can they increase the comfort level of managed care organizations in engaging with this jail-involved population, which has been mostly invisible to them?
Yeah, we had a meeting in Washington about, I guess, 3 or 4 months ago with you, and we invited several health plan officials, United, Aetna, some Medicaid-only health plan officials. And to say comfort or enthusiasm would probably be a slight exaggeration in this regard. However, as was pointed out earlier, the population that is cycling through jails has a lot of the characteristics of populations, certainly on the serious mental illness side, that some of them have had to deal with. Not that physical health and behavioral health is as integrated as it should be. But information systems and data and being able to predict what is likely to occur and to be able to direct interventions toward those that most need it will give them more comfort. And to know that there aren't reams of paper files, as was depicted in Camden, as opposed to electronic information, as Dr. Bender has described in New York, would be comforting to the degree possible. And I appreciate in your paper and in your remarks the degree to which it isn't perfect on your side yet, and haven't gotten pharmacy integrated, et cetera. But it certainly isn't perfect out there either in the healthcare system. And at some point we'll probably get to what's the capacity of community-based behavioral health providers, particularly on the substance abuse side, to generate anything like electronic health information.
Yeah. It is pretty amazing to see the system in New York. Homer, since the EHR has allowed you to track aggregated data on medical conditions from which you can see certain patterns emerging, has the tracking of injuries created tensions with security?
Yes. I think that, we have been paying a lot of attention to injuries for a couple of reasons. I think, first of all, it accounts for a lot of our work. I think anybody who works in corrections, particularly in jails, spends a lot of time on injuries. I think that also it's something that happens to people. So we are very keen to articulate this notion that most medical problems that people come to us with, by and large, get better while they're with us. That's not true for everybody, and that's not true for every condition, and there are things we struggle with. But injuries represent one of these things that happen to people. They didn't come with this injury, and they're in this system, and that happens to them. And part of it is that we put a lot of work into caring for injuries and tending to injuries. But part of it is we need to think about, if we're the medical providers in a system where a bad health outcome happens to people, it's our responsibility to find out about it. And so it has created a fair amount of tension, but I think that it's part of this third, I don't know, it maybe falls into like patient safety and population health and human rights, but like these are our patients. And so if they get injured in our system, we need to find out why. You know, now that we have a structured template that every time somebody who's injured is seen by one of ours, it's about 1,000 times a month in our system. So between the second and third most common injury type, because we put in all these structured data fields that the CDC uses to track injuries, and month to month is either the second or the third most common. But a couple hundred times a month, we have a slip and fall. Nobody in this room really believes that people are slipping and falling at that rate. And so even more alarming than just injuries happening to our patients in the place we work. I mean, you think about what goes on in an incident report when somebody slips and falls or whatever happens in a hospital, is that the second or third most common type is something we have no idea what it is. We could speculate, right? We could say maybe these people got beat up and they didn't want to talk, or maybe they were like goal-oriented and laid down on the floor, but we don't know. And so the EHR provides us a venue to get more detailed and reliable data about this so that we can think about how do we prevent injuries, who are the vulnerable groups, you know, LGBT patients, patients who are mentally ill, patients who are in solitary confinement, they're at high risk based on the data we're starting to accumulate. So yeah, that creates a lot of friction with security, but you know, our job as the health providers is those patients. It's not security, and we conform to security and we accede to their rules, but it allows us a structured, reliable format to come up with data and say, this is happening to our patients in this setting, so we have to figure out a solution.
In my introduction, I talked about how healthcare in jails is difficult to categorize and how there were challenges of fitting what was an EHR designed for a primary care practice into a jail environment. Would you care to elaborate on fit issues that would give the audience an idea of how complex healthcare can be in jails? Because it's a very mixed group here today.
Yes, emergencies is a good example. So we probably have 20 to 30 emergencies across our system a day. So many of those emergencies, people will respond to a housing area. So, you know, a doctor, a nurse, a PCA or two grab a bunch of equipment, they go out to the housing area for a man down or for somebody in distress. So all that's going on out there needs to be documented. So they get there, they take vitals, there's some record of what's going on. So when you start with an ambulatory care EHR, most of these are visit-based, where you're, like when we started with our EHR, you know, we're scheduling visits and people are like, you're coming to the doctor's office, they come to the doctor's office, you're clicking on a visit that's on a calendar, the provider's merging it in and they're sitting down, the nurse or the doctor. And so if you think about in an emergency, so you have medical contact out in the housing area, you have along the way, if you do some sort of intervention on the stretcher on the way back, and then you get into the clinic, you know, somebody who has, let's say, a stroke, you know, they may have like 5 sets of vitals in a very short period of time. And so in a format that's really structured for like, you see the nurse once, you see the doctor, boom, you're done with your clinical encounter. It can be tough to shoehorn that in. Now we have, with Rick's help and ECW's help, built in lots of ways to accommodate that. I think the other thing you referenced was infirmary care, where we have round the clock. You know, we have 100 men and about 30 women very ill in a setting with 24/7 nursing and doctor care. And so it's really difficult to document all the different types of things like wound care, you know, vitals checks, neuro checks, things that the ambulatory care record is not built for. But conversely, the inpatient records would provide the same challenges for what is the bread and butter is our ambulatory care setting.
Could I interject, Ben?
Yeah, sure.
I did, as you pointed out, I did get to visit Rikers and see the clinic and see the process. And as someone from outside and who's concerned about the fact that all of these individuals are going to become Medicaid eligible and they're going to become part of the Medicaid system, getting that picture across to the stakeholders with whom we work generally would be pretty important. So, Nancy, I don't know if you want to do another film, but Camden is one picture. The what's going on in New York, and you were there, is another, because of the robustness of the activity within your health system inside the jails. I don't think many people in Medicaid or in the Medicaid stakeholder community know that. They just don't realize that, and so that's good news for them in some ways. Be particularly good news if there's more connectivity generated between the two sectors. And I work with Medicaid directors across the country, Medicaid leaders, who for the most part don't know about this population that we're talking, just don't realize that this is coming. And it could be 4 or 5 million, people that have serious issues that also have jail issues that they're going to be responsible for. And just getting that information out in front of them so that they're more aware of it and aware of the demands that might be associated with that, particularly to connect to the departments of corrections, et cetera. That's a very valuable piece of connectivity that's going on in this meeting.
Steve, I know in our last conference, November 17th, 2010, we often mentioned David Mancuso's studies from Washington, D.C. How will health information exchanges in jails better enable evidence-based treatment?
So I didn't tell you that I was a little perplexed by how to deal with this question that you had fed me beforehand. Thank you, Ben, for doing that. And I'm still a little perplexed because evidence-based, and I should defer to you, and I will defer to you quickly, evidence-based treatment for people who have multiple comorbid complex conditions, I don't know if that's an oxymoron or, I don't know if it exists. So that's why I'm somewhat perplexed by the question. Now, we know that care management is critical. We know that transitions in care are incredibly important to pay attention to. But beyond that, what's the evidence base? Please, Dr. Ventures, help me.
Well, I think the EHRs have a variety of tools that can really assist clinicians. So the clinical decision support tools, which are part of the meaningful use rubric. But I think that even things as simple as structured templates. So one of the vexing, infuriating for medical directors issues is when people is helping your clinicians differentiate between a hypertensive urgency and hypertensive emergency. So if somebody comes into your clinic and they just have super high blood pressure, but they're fine, that's called hypertensive urgency. And it's not an emergency. You don't need to hit them with all sorts of medicines that are going to drop their blood pressure to the floor and make them faint or make them have a heart attack. But we consistently would see people come in with a sky-high BP. They get a medicine that's going to drop this medicine clonidine that makes us crazy. People get it. Their blood pressure bottoms out. They faint or they get a little ischemic or, they have a bad adverse effect of this. And so we have built templates into ECW that in these settings hopefully guide the clinicians to think about, is this a hypertensive urgency or is it an emergency? Do they have some symptoms like they're seeing spots or they have a horrible headache or something, or they have some protein in their urine, to help them track between these two? Because I think that in our settings, we're most concerned with these life-threatening emergencies. And there's everybody knows algorithms around acute coronary issues. So in the hospitals, in the EDs, every doctor out there knows, if you think somebody's having an MI, you do ABC. But there are many other emergencies that happen all the time where we want to assist the providers in what is an incredibly chaotic setting where, the patient's screaming, the officers are yelling, you're in a clinic, it's hard to keep track. The EHR should help them with those tasks of, let's stay at, is this our frame of reference or is that our frame of reference? And if this is our frame of reference, what are the things we want to make sure we do?
It's very interesting because that's when I started going to jails many years ago. It is that trying to control the chaos that was most salient. So it's now I'd like to have the audience participate and ask any questions of our panelists if they would like. We have people here with microphones, so the people with microphones, if you could raise your hand, and they will. Yeah, the participants are raising their hands up here, please.
Thanks. Bob Balecki, Cumberland County Jail in New Jersey. I was wondering if you could give us some advice on getting ready to go to electronic records. We have shared intelligence for many, many years in the jail community throughout the state and sometimes nationally. And we're running into problems even after we've been doing this for a long time with everybody doesn't have the same IT system. So we can't share. We have the information, but everybody's doing their own thing. I was just wondering, did you have that experience when you rolled this out in New York, and was it a problem that different people bought different systems and then you couldn't talk to each other? I don't want that to happen.
Well, I'm sorry to hear that because it will happen. But yeah, we did have that problem, and I think that there are multiple ways. Every one of these electronic health records has a medical summary. For instance, we send people to the state DOC system all the time, as all jails do, and so we still actually use this handwritten state transfer. It's a medical and a mental health summary because we're still working on getting the EHR to produce a summary that we think is exactly what we need. So it's an important consideration. I think that no matter what EHR you adopt, though, there are all these swirling around. Rick is kind of the master of all these for us, but all of these different ways that health information exchange is being explored and promulgated. And I think that what you really have to do is think about who are the people you share information with the most, and then come up with a plan with them. So for us, we have a monthly meeting with the state DOC, and so we know we're on board with them. They know that we have this electronic health record, that we're still going to use our old system of sharing information, and that we're moving towards something else. And I think that inevitably, there will be some very low-tech solutions that you have to just persist with for a little while, but the goal is to get rid of all those. And so I think that all these electronic health records can produce something called a CCD, which is a little medical summary, and that's good for the community and sharing. It's a standard medical summary that I think CMS, some federal authorities have blessed as appropriate. What's important to know is that leaves out a lot of mental health information and substance abuse information. So your patients and our patients, the two most common diagnoses are a mental health diagnosis or a substance abuse disorder. So, it's important to think about as you buy electronic health records, pretty much none of them off the shelf are going to really accommodate sharing that kind of information. They're going to get the meds and they're going to get the diagnoses that are on, the problem list, but they're going to miss a lot of important information about Axis 4 or 5, or, is it substance abuse or is it substance dependence. And so I think you basically just have to prepare yourself and allow for the fact that you won't be able to share information seamlessly, and then figure out who your key partners are and just come up with a plan.
I would just like to add, when you hear acronyms like that, CCD, Continuity of Care Document, Cochs staff has prepared a glossary, which you have, and in fact, that acronym is in the glossary. So if you're a little lost, feel free.
Because I forgot.
Yeah, it's easy to forget the acronym. Next question, please.
Yeah, hi, I'm Joan Randell from the Nicholson Foundation. I have two questions. One, I just confirmed with Rick, I know from New York, that most of your patients are on Medicaid. Previously coming into the jail, and of course, so one of the things I was thinking of is, as the Department of Health, you could get access to the Medicaid Management Information System. You could, although there's a time lag, maybe 6 months or so, you could look at the diagnoses that people have and where they were treated. So that would give you something, and you could probably just print it out. And I used that with a project that we had in New York, and it was incredibly helpful. And it also had mental health and substance abuse information. So as an interim, before you have your HIE, I think that might be something that you might want to look at. Second thing I wanted to say is, since the people already on Medicaid, I was surprised when I asked Rick if you don't bill Medicaid for their services, because you do the intake immediately, pre-adjudication, predisposition, right? So you don't know?
No.
Oh, post-arraignment. I see, but in some jurisdictions, they do bill. New Mexico, Pennsylvania, and the feds have allowed it. So a lot of you are talking about, people are talking about when, if, everyone's going to get on Medicaid. In New York, everybody's on Medicaid because of the 1115 waiver. But in 2014, in other places, the prohibition, if somebody's incarcerated, I haven't heard anyone say that that's going to change. So why do you think, there's this discussion that it's going to be so important, but what really is going to change unless that piece of the Medicaid regs are changed as well?
So I'll defer the regulation question and answer the first one, which is, you're right, there are existing pools of information that could be incredibly valuable to us. One of the things I didn't mention in my remarks, which I should have, is one of the kind of dispiriting aspects of rolling out an EHR is that just because you have the information there, people are not going to necessarily go look at it. So we had always contented ourselves with the fact that our old systems, the reason people never found out that the guy was here 2 weeks ago and had this and that, and this was a diagnosis, was because it was hard to do. Well, we've now made it easy to do, and still, often it does not happen. And that's with having a right pane that opens up, that says, this is the problem list, right? And so all the problems on there. So look at these problems that are directly in front of your eyeballs and tend to some of them. And a lot of the times that happens. But I think that the thing that we're very cautious about is that it's our experience that particularly on intake, that's chaotic, that's fast, that you want to get done, where it is important to find out that information. Was somebody on an atypical antipsychotic 3 weeks ago? Because you know what, that's a patient we don't want to mess up. That is also the same system that is so chaotic and so time sensitive that we just have this process-driven thing. People are trying to get through it like it's like they're working a shift. And so in the individual encounters, like a mental health intake, like a chronic care visit for something, those are the venues where we can make use of some of these pools of data. But on intake, we have struggled to get people to use the information that they have actual direct access to. And so we're sometimes a little cautious about expending huge amount of efforts to link up with other systems. Even though you are right, it should bring great benefit to our patients.
And before you defer to me, because I'm going to defer to somebody else, on the Medicaid regs, what is striking in New York as well, you're embedded within the health system for the city, and yet, and there, I think, Joan, in New York, there's a suspension of Medicaid, not a termination of Medicaid. Yet, I don't see that there's a lot of Medicaid billing going on within any of your jail system. So that begs your question, and that is part. I mean, people talked about the theme of connectivity here. I think there's also a theme of discovery here. We're in a discovery mode, trying to understand, certainly on the Medicaid side, understand what the opportunities, obligations are with respect to this population. And I don't know that New Mexico and or Pennsylvania, which you cite, how much of that is going on within the respective states and how public they are about it, and whether they tell people in Washington. Yes, thank you. I thought so. So we won't talk about it anymore. Erase the tape on that. But I think it is a direction that we will keep pushing forward toward, and there will be more known as we get there. And there are other people in the audience, if they wanted to raise their hand, who could say more about what the law says about coverage of people in jail, pre-adjudication, et cetera. But it wouldn't be me that would give you the best information on that.
I think Dr. Summers is our in-house expert, so what can you help us with this question?
Microphone, please.
Unrelated, Dr. Summers, right?
That's right, completely.
Thank you.
Good morning. Oh, I just knocked my glass over, excuse me. Yeah, I mean, I think it's still unclear, you're right, about whether we're going to move to a point that pretrial detainees in jails can actually bill for Medicaid. And I think that there's still a lot of work to be done. We'll continue pushing there. It's actually very complicated. While I think that we would like to be able to have that option, I think, as many of you know in this room, probably more than most of the people driving those discussions sometimes, being allowed to bill Medicaid does not mean that you are eligible to actually do so. I think that would then require a huge amount of effort on all of our and others' behalf to get a lot of jails up to the point where they can actually bill for Medicaid. But I think the important thing that I find so exciting about these discussions that we're having is as the country is moving towards recognizing that we have to really make some seismic shift changes in how we're doing care for the most vulnerable and then the most expensive patients. Correctional health is actually being inserted into that dialogue in these early stages. And I think that's where it's crucial for us to keep the dialogue going, because it's not only about the few people, most of whom are in this room, who care about incarcerated populations, who are really going to move this, but it's incorporating. It's being in a position like New York City, I think, is kind of leading the pack on, that allows us, with having an electronic health record, to be able to offer data instead of just yell and complain and say, we know how sick our population is, we know what their Medicaid expenditures are, we know what their preventable hospitalizations are, we hopefully soon know what happens to them when they leave our custody and what happens when they come back. And I think that's the way that we drive change to those outside of the jail and prison communities.
Hi, I'm Jan Root with the Utah Health Information Network, and I have to admit that I'm on the tech side, not the correctional prison side, so I'm learning a lot of new acronyms today, which is great. I just had a question for Dr. Warner. I know that New York City has a number of HIEs. I have spoken with them many times, and you mentioned that you're in conversations with the Department of Corrections about exchanging data, I guess, within the correctional system. Have you talked with the HIEs?
Sure. Rick Stazeski, who's right here next to Dr. Summers, is our point person, but we have, the plan is for this statewide Rio system to go live soon in New York State, and we will be theoretically pushing data into that. I don't know who else will be pushing data into that system, but we have, as I mentioned, Rick could probably list 6 or 7 different ways that he and we are exploring the data exchanges through the HIEs and through other mechanisms as well. And I feel like, it's in 2008, it was a certain crazy world, and everybody was snapping up these EHRs in the community. And now in the community, you look around, and some of those EHRs are there, and a lot of them are gone, and a lot of the things people hoped for those did not happen. I have this kind of similar view towards all these information exchange possibilities right now. It's incredibly exciting and heartwarming, but I think really none of us knows which of those things are going to be alive in a year or 6 months, or who's going to dominate. And so I think it's important to put effort and energy into your basic tasks, which is taking care of people in your system, and an EHR is a good way to do that. I think you need to devote some resources to the health information exchanges, because that is definitely going to help you. But I think it's difficult to ascribe, it's hard to pick a winner right now.
Yeah, when you read about HIEs, the one word that always pops up is sustainability. Sustainability.
Yeah. I also would say that it's nice that somebody from the technical side is having a hard time with jargon and nomenclature. It's back at you.
I'm Roberto Hugh Potter from University of Central Florida Criminal Justice and a recovering Fed. I'm going to ask this question as kind of an overarching question for the day. What you all are talking about really seems to me only to apply to the 75 to 100 largest jails in the country. There's another 2,900 or so whose ADPs, average daily populations, are much smaller, whose health care may be provided by contractors, may be provided by the EMT across the street at the fire department, whatever. Is this a conversation, and again, Rikers, as I've pointed out elsewhere, is so unusual in terms of it being a post-arraignment reception center instead of a full-service jail. Same here in DC. Should we really be restricting this conversation to large jails? Or is this something, and I'd ask Dr. May and others who deliver care across multiple jails, how does this conversation actually affect the vast majority numerically of jails that hold about 40% of the people on a daily basis?
Hugh, I'm Steve Rosenberg, for those of you who don't know me. Hugh, I'm going to ask you to defer that question until after the second panel.
Mark?
Ben? Now that we're Mark Stern, I'm from the other Washington. The real Washington. The big Washington. So I'm conflicted, and I know you don't find that as a surprise. On the one hand, my heart, I'm passionate about electronic health records, and I think they're the best thing since sliced bread. And then my evidence-based medicine part of my brain says we don't have a whole lot of evidence to support better outcomes. There is some in the general community, but as you guys have talked about today, our population is different, our structure is different, our processes are different. And I don't know that we can extrapolate the data from the community to what happens in our justice-related population. So I think we're going to be hampered. I don't know that that's going to stop the engine from moving forward, but I think I feel hampered by not being able to say that we actually improve patient safety, public health, and victimization or human rights by the implementation of a health record. And in some ways, again, as we've pointed out today, there may be deleterious effects. There may be things that happen, that undesirable side effects of this new medication, of this new treatment, which is the electronic health record, that may actually make things worse. I mean, we already know, for example, that when a practitioner sits in front of a patient, now there's less eye contact with a patient because they have a screen instead of a piece of paper. Does that have bad effects on the outcomes of health care? So I'm conflicted. If anybody has any medication to help me before the day's out, I'd appreciate it, and that's all I had to say.
So I think that's a good point. I think that rarely in the ramp up and implementation of an EHR do you have a lot of room for cynicism or like frank discussion. I will say I'm not and have not ever been like a cheerleader for EHRs. I would consider myself now a qualified proponent of the system, but quite heavily qualified, just from the standpoint of seeing patients. But I do think that, first of all, whatever evidence, if there was a boatload of evidence that EHRs yield better outcomes in the community, I still would be incredibly skeptical about the application of those results or data to the correctional health setting because it's so different. Secondly, I think that what you'll need to do for those of you who are skeptical and thinking about it is watch big, medium, small-sized jails as they implement EHRs and talk to them a year or two out. And I think that will be the evidence. There's not going to be a large amount of level 1 evidence about health outcomes in jails, particularly where people are there. People in jail for 30 days or less on average, and so adverse effects of anything that happens in a short-term setting, those adverse effects are going to be felt in the community. So given the fragmentation of information that we've just been talking about, you're never going to find those adverse effects if indeed, as you suppose, EHRs might be a bad a risk, a health risk. the patients will accrue the outcome of that risk in the community, not in jail. So I don't think you're going to be able to look in jails and find good, solid evidence. I think what you're going to need to do is talk to people who deliver health care in jail, talk to patients, talk to community providers, and see if it's improved things. And I think that that's disturbing because it's qualitative, and it heightens your sense of internal conflict, I'm going to bet. But it's the best we've got right now.
Yeah, and in that vein, and in picking up some of the discussions, although not the one I'm not supposed to pick up, about smaller jails, picking up what Cynthia was saying too, that the fact that New York is doing this and has such a big system and has so many people and is going to be able to generate so much data, that's a good thing. And it goes back to what you were talking about, David Mancuso in Washington. If you begin to generate some information about what's happening with the population, what kind of health conditions they're dealing with, you begin to be in a position to communicate with policymakers, Medicaid directors, Medicaid health plans, et cetera, about the scope of the problem. And that's a start. That's a very important start. And that's why the work that Mancuso has done in Washington is so valuable for this discussion. He's able to convince or convey to people in decision-making roles that there are connections between substance abuse, behavioral health, corrections, healthcare expenditures, et cetera, and presto, people start paying attention to it. And the same thing can happen here, which is a value independent of whether or not it can translate and be replicated at the small or medium-sized jail level.
I'm Seema Gajwani from the Public Welfare Foundation again. I'm going to go back to a couple of questions ago when I believe you asked the question about Medicaid billing. And Dr. Summers commented that it remains unclear if it's something that's possible to get Medicaid reimbursement for pretrial in-custody populations. But you also said that it's really interesting that we're starting the dialogue and including correctional populations at this point. And I think that dialogue should lead us to the point of questioning, although this is beyond the purview of this meeting, but questioning if these large pretrial populations need to be in our jails. In some counties across the country, there are 60, 70, 80% pretrial populations in jails, many of whom have low risk for recidivism, many of whom have some of these behavioral health issues that prevent them from being released to the community. And these populations, if they were diverted before they entered the system at the very front end to community-based treatment that would address those underlying issues, would be eligible, obviously.
Thanks. And because we're talking about New York, I just want to talk about a little bit of something that Cochs has been working on this very topic. So many of you may know that states now have a Medicaid option to create this health home benefit, which is a 90-10 federal state benefit to manage the care of individuals who have 2 or more chronic diseases. And New York State is in the process, and actually they have some of their health homes up in some of the boroughs at this point. And we've been thinking a lot about the fact that this is not just folks with hypertension or diabetes, but also folks with substance abuse and behavioral health disorders, and how do they fit into health homes. And so one of the things we've been working on with New York State is putting reincarceration as a metric in the health home, which are all going to be tied together into HIT systems. And so I think part of, Seema, what I'm hearing you say, and I think this is part of the opportunity, is we haven't looked at the availability of Medicaid funding as a way to divert pretrial individuals from custody. And that part of trying to figure out metrics that we can use that are tied to Medicaid funding has to do with how do we align incentives within our system so that we use health information technology to appropriately provide service to individuals in the community who have Medicaid cards in their pocket and who have behavioral health needs within that frame. And I think that is something that we at Cochs are starting to pay a lot of attention to. So I appreciate you bringing that to our attention. We have time for one more.
Okay, one more question.
While you're looking for a question, I'll just comment on that too. That I think that part of the opportunity that has been presented with the Medicaid expansion is that you are going to bring attention to the degree to which there isn't enough community-based treatment out there for the populations that you would like to divert, and that's another issue I know, Steve, that you're concerned about and that we're concerned about. So when they have a card, that'll be a reimbursable service, presumably under the card, and that will begin to generate, hopefully, more community-based treatment, which, of course, will need HIT to match up with all the other things we've been talking about today.
Well, if there's no further questions, I'd like to thank, once again, Dr. Summers and Dr. Venters for being here. It's greatly appreciated.